we'll take on the next.
Thank you.
Because, this was a keynote address. The next is the best paper from Uttarakhand State Ophthalmical Society, which was awarded Dr. M.C. Luthra Gold Medal. Will be presented by the winner of the gold medal was Dr. Vikas Mittal. He will be presenting the topic sutureless anterior lamellar keratoplasty techniques and results. And the paper is a competitive paper.
Thank you very much, sir. In the last 10 years, the incidence of lamellar keratoplasty has increased a lot, and mostly it's because of introduction of component surgery, where we replace only the diseased tissue. In anterior lamellar keratoplasty, there are various surgeries that has been described depending upon amount of stroma that is replaced. In a patient like this who has a corneal scar only in the anterior stroma, superficial anterior lamellar keratoplasty can be performed, and the basis is the management of free cap during the LASIK. Based on this, with this background in mind, we conducted a retrospective study of prospectively collected data over a period of 3 years, in which superficial anterior lamellar keratoplasty was performed using automated microkeratome for corneal scar in anterior 200 microns of stroma. Minimum follow-up was 1 year. Outcome measure was uncorrected best corrected visual acuity and challenges if faced any. Let's have a look at the surgery. This is the same patient who was actually a resolved fungal keratitis with 2400 vision, scar in anterior 200 microns. First, the whole globe was mounted on eyeball stand, and then the microkeratome, here the Hansatome was used. The parameter was 9.5 millimeters in diameter and 180 micron depth. Similarly, as we do LASIK, the thing here is, once we have created a hinged flap, after that, whatever portion was remaining that was dissected, the idea was to create a free flap. It was very important to stay in the same plane. Once the whole thing was dissected, it was cut with the corneal scissor, and this was the graft which was prepared. After this, the patient was taken in OR. The same steps were repeated. As you can see here, the diameter is 8.5 millimeters, and the depth is same. The idea is to see what is the diameter that we are getting, and then later on we can punch from the graft the desired diameter. The same steps were repeated, dissected and cut. After that, the graft which was prepared was placed on the stroma. This has been punched after taking the diameters. I am used trypan blue to delineate on the Teflon block, which is white. And after placing it, just like we do a management of free cap, 2 Merasol sponge were used to drain the interface fluid, first horizontally and then vertically. Very important to dry it for good 10 minutes to ensure that there is good adherence. After this, I'm just checking if the folds are getting transmitted, and a bandage contact lens was placed. Let's have a look at the post-operative course. Same patient, 2400 pre-op, and he was 2040 in 3 weeks period. As you can see, the scar is only in anterior 200 microns. This was replaced by graft. As you can see, the graft is pretty thick because it was stored in moist chamber and was not in MK or Optisol GS. But later on, it even compressed and reduced to 218 microns. As corneal surgeons, we are really worried about this graft-host junction disparity, but over a period of time, it merged very well with the host tissue. Another such patient who had a corneal scar and had a clear cornea post-operative. Overall, 10 patients were done. They had healed microbial keratitis, mainly indication. 2 patients had partial limbal stem deficiency, which was treated with SLED. Post-operatively, apart from this patient, all patients had 20/40 or better vision. This patient had an epithelial downgrowth, which was managed with flap lift and debridement. If you see the astigmatism, there were many patients who had the significantly hyperopic astigmatism, which generally maybe depends on the host, and the scarred cornea are already flatter ones, and that refractory error gets transmitted. Other challenge was that you need a whole globe instead of cornea, and you can use only for 200 microns. But then there are no suture-related complications. This has been reported by Theosilla. They had used 4 sutures although, and results were similar to our study. Sutureless ALK also has been described in the literature. This was 2 studies which I could find. One of our patients had epithelial downgrowth. To prevent that, a 2-stage procedure has also been described, where they make a flap first and then they go back in OR after 6 to 8 weeks and then punch, then refine the required diameter of host and then the graft. Use of femtosecond laser have made the things very simpler and you can be very specific. But overall, I feel that the SALK seems to be a good option for anterior corneal stromal pathologies. It will be cost effective because you can do it even without femtosecond laser, and it may provide a good quality of vision without suture related complications. But then the largest study, because the number of cases was small, so large study would be needed to substantiate it. Thank you very much.
Just one question.
Yes.
Did you take into account the corneal thickness? Did you do the pachymetry for?
Yeah, that's right. All cornea were pachymetry was done in all patients, and it was like somewhere around 500 microns, 480 microns. These they tend to be. But the main thing was whether
you did not do one thin cornea.
No. That's right.
So how accurate was OCT measurement of the corneal opacity depth? When you made the cut, there was still some opacity in the video you showed.
Yeah, there was some opacity. One of the cases they've reported, what you can do is, after doing it, you can do a PTK also. So sometimes, yes, there were 1 or 2 cases, there was some scar which is remaining, but you see, if the most of the refraction that gets taken care at the anterior surface. So even if those small scars, they don't interfere with the vision, or it's just minimal.
How long do you keep the contact lens?
Contact lens is kept generally for 5 to 6 days in place. Generally, after 2 or 3 days, the epithelialization is complete. And once the epithelialization is complete, you can remove the bandage contact. I kept it for a week or so.
Okay, thank you.
Thank you very much.
We call the next speaker, Dr. Sirish Kumar K. He's speaking on retrospective analysis of surgical outcome of dual head pterygium management, our surgical experience.
Good morning, everybody. Respected chairpersons and my dear friends. This paper doesn't carry any financial interest. Operating upon a dual head pterygium is quite a challenging and a difficult task, in the sense you have 2 bare steras to cover with the graft tissue, so you might have to have enough tissue to do that. The options available are, in a primary dual head pterygia, you have conjunctival autograft, which can be split or superior inferior. You have epithelial sheet transplantation, amniotic membrane transplantation. Of course, in recurrent pterygia, you have limbal conjunctival autograft. Ours was a retrospective interventional single-centered study of 55 eyes of 50 patients between 2006 December to November 2012. We had 50 eyes with primary pterygia and 5 with recurrent dual head pterygia. Age group was between 20 to 72 years. 5 patients had a bilateral presentation and 45 had unilateral. The sex ratio was female to male ratio was 58 to 42. Of the eyes, 45 eyes underwent split conjunctival autograft, 4 underwent superior inferior conjunctival autograft, 3 had epithelial sheet transplant with CAG, and 3 had limbal conjunctival autograft with CAG. This is a case of dual head pterygia, where after the excision of the pterygium, as you can see here, this is quite fibrovascular. All the recurrent pterygium are quite fibrovascular. That one thing has to be kept in mind. And the conjunctival limbal conjunctival autograft has been raised. It is split into 2. I'm sorry. After raising the conjunctival, peeling off the pterygium, the limbal conjunctival autograft is being raised here. It is split into 2, and it is glued to either side of the bare stera, as you can see here. Things that have to be kept in mind with a limbal conjunctival autograft is that the limbal orientation has to be maintained and brought in approximation with the limbus of the cornea also, and this is on the other side that is being placed. Things that have to be considered in the limbal conjunctival autograft is that we have to secure the edge of the limbal conjunctival graft with the stera at the edges, as is shown here, so that it doesn't slip out. That's one important thing that has to be kept in mind when you are doing a limbal conjunctival autograft. This is a case of again a primary dual head pterygia. This is a primary pterygium, As you can see, we have raised the epithelial sheet from the underlying pterygial tissue. We are dissecting the epithelial sheet, and once the pterygium is excised, the epithelial sheet has been glued to the base sclera, as you can see here. This is a case of again a bilateral primary pterygia, where after excision of the pterygium, inferior conjunctival autograft has been taken and placed on one side, and it is being sutured. This was the time where we used to suture the conjunctival graft. Now recently we have started using the glues, and the other side has been sutured again. So all the patients had antibiotics for a week's time and steroids and lubricants for 6 weeks. Follow-up was between 3 to 53 months with an average of 14 months. 5 patients lost follow-up after 2 weeks. The complications we could face were graft retention in 7 eyes, of which 1 was from the epithelial sheet transplant group. Graft loss was seen in 3 patients. These were the patients, it was a time where we got the fibrin glues, and it was one of the companies which did not function well, and this was abandoned later. And we had granuloma in 1 eye, and it was not of any visual significance, but it was excised. 1 patient had a recurrence. It was from the group of graft loss, that is in the epithelial sheet transplantation group. So in conclusion, we could prove that epithelial sheet split conjunctival graft is one of the effective and the safe methods that can be used for dual head pterygia. Of course, if there is non-availability or any other thing, then you can use superior and inferior bulbar conjunctival as the second option, and epithelial sheet transplantation is the third. Of course, in a recurrent recurrent pterygia, we have limbal conjunctival autograft. Yu et al. Had studied this particular technique with a primary dual head pterygia in 20 eyes. He had used conjunctival rotation autograft with combination of CAG. 7 had recurrences. Evzer et al. Had used MMC in both primary and recurrent pterygium, 13 eyes of 13 patients. 1 had recurrence in the recurrent pterygia group, and Maheshwari conjunctival graft for primary, 7 eyes of 7 patients. We studied almost 4 techniques. We tried with both primary and secondary in 55 of 50 patients, and 1 had a recurrence. This was mainly because of the graft loss. Thank you.
Thank you so much. We have next speaker, Dr. Prateek Guzar from Gwalior. His topic is Descemet stripping endothelial keratoplasty with insertion of donor button using cystitome.
Keratoplasty, that is DSEC with insertion of donor button using cystitome. I have no financial interest in the material and technique present in this presentation. As we all know, DSEC has emerged as one of the most important breakthrough in corneal transplant surgery with distinct advantages over penetrating keratoplasty. But the problem arises in the initial cases when the donor graft insertion can be tricky and challenging, leading to a higher endothelial cell loss. There are various insertion techniques and devices available in the market. You can do a suture pull-through or deco or endoglide using glide sheets, like whatever. Here I will be sharing my experience in DSEC cases in which I have inserted the donor corneal button using cystitome. It's a prospective international study including 37 eyes of 37 patients with corneal decompensation. The pre-operative and post-operative evaluation included complete ophthalmological examination. Endothelial cell density of the donor cornea were recorded. Post-operatively, endothelial cell density was recorded after 6 months on every visit. 3 patients with raised IOP were maintained on anti-glaucoma medication. All the patients were done under peribulbar anesthesia except 1 case of congenital hereditary endothelial dystrophy, which was done under general anesthesia, and donor button was prepared using manual dissection technique. In all the cases, a temporal 6 mm sclerocorneal tunnel was made. respiratory access was done. Then scleral bed was coated with 2% HPMC. Now at 27 gauge needle is bent at the tip and this forms our cystitome. The donor button is placed endothelial side down on the bed coated with viscoelastic and it is gently engaged and pushed inside the anterior chamber. With the other hand you lift the roof. Once completely inside the chamber you disengage and come out. Suture the main port with 3 10 nylon sutures. Complete airfill for 10 minutes. This is first post-op day. This is 6 months post-op. So in all 37 cases were done using this technique. 22 were male and 15 were female with a mean age group of 57.52 years. The most common etiology was pseudophakic bullous keratopathy in 28 patients. 5 patients had Fuchs endothelial dystrophy. 1 patient had congenital hereditary endothelial dystrophy. 1 patient had iridocorneal endothelial syndrome and 2 patients had aphakic bullous keratopathy. The mean follow-up period was 9.16 months. The mean post-operative astigmatism was 1.62 diopter. Mean post-operative spherical equivalent in non-aphakic clear grafts was 2.12, indicating a clear hypermetropic shift. The mean graft size was 8.01 millimeter. 35 grafts were clear at the last follow-up. Mean central graft thickness measured using anterior segment OCT was 135.62 micron. 3 patients had graft dislocation noticed on first post-operative day, which was managed by repositioning and rebubbling. 2 patients had primary graft failure. There was a significant improvement in best-corrected visual acuity. Preoperatively, all patients had BCVA of 6/60 or worse, while post-operatively, 25 patients achieved a BCVA of 6/24 or better. Comparative to the pre-op cell count, there was an attrition of 29.76% in the endothelial cells. Coming to the discussion part, as we all know, DSEC has emerged as a procedure of choice for endothelial dysfunction, but the non-traumatic insertion of the graft remains a challenge, especially for persons who are just learning and converting from penetrating keratoplasty to DSEC. Various insertion technique and devices are there, as I have already mentioned, but the thing is, learning with them can have a steep learning curve, and some of them can be really costly. So you have to come up with a procedure which fits in our pocket and endothelial friendly at the same time. Now if we look at the various studies published comparing different insertion technique and incision, Busin glide versus forceps assisted, endoglide versus Busin glide. Now here is a very good report published in American Academy of Ophthalmology comparing safety and outcomes in DSEC. They have reviewed all the published literature in DSEC and it is done by Dr. Lee et al. What they say that the mean endothelial cell loss after DSEC cases, it's around 37% at the end of 6 months, and the graft survival is around 94% at the end of 1 year. In our series, the endothelial cell loss at the end of 9.16 months was 29.76%, and the graft survival was 94.5%, which is comparable. So to conclude, DSEC with insertion of donor button using cystitome is a safe and easy to learn technique. Why it's easy to learn technique? Because these are my initial cases when I was just converting from PK to DSEC, providing a hassle-free graft insertion and good visual outcome in our case series, and it is cost effective too. Thank you.
So, have you compared at your own center with your own hands different techniques?
So,
like comparing it with the Western, right? With your own technique, insertion techniques with cystitome and others.
These are my initial cases, so I was just doing this technique. So now I'm in a procedure to compare it with the tacophasia.
Next person is Dr. Samarth Kumar Basan, Kolkata. He is speaking on periodical endothelial cell loss in DSEC in a consecutive 550 cases over 5 years.
Thank you.
Thank you very much. This is just to share the periodic endothelial cell loss in DSEC over last 5 years. I do not have any financial interest to disclose. You know what is DISEC, but there are only few reports in the literature which compares the periodic cell loss. And then only one data is available up to 5 years with graft survival and endothelial cell loss, that is by Price et al. I just wanted to see what is going on in my hand and over the period of last 5 years. These are prospective non-comparative longitudinal interventional case series, and the period of almost 6 years. These are DISEC, and some of them are combined surgery, and also additional surgeries are also there, and all are same procedure like perivalvular anesthesia, sclerocorneal tunnel, and all taco folding technique, BSS here. And pre-op donor endothelial cell density were more than, this is the protocol in our center, that 2,400 cells, and measured by two different types of eye-bank specular. And post-operatively, we had again two types of specular with TopCon 2000p and later on 3000p. And these are by technicians usually done with a mass fashion. And if you see the series and pseudophakic bullous keratopathy, pseudophakic bullous keratopathy or edema is about 60%, and Fuchs dystrophy is about 25%. And other small indications are there. But most of we have also the different kind of media used. Like we have used MK medium in most of the cases, but sometimes we have used Optisol GS, Usol C, and Life4C, different pyro. But the main part is depth to preservation time, because we do collect only in situ preservation, so they're all are less. So after 3 months, this is almost all patient we get this cell loss is 17.9%, and then again after 1 year, 2 years, 3 years, 4 years, 5 years, these are not the same group of patient, because it is very difficult to have point follow-up for all the patient. So this is the average of patients coming at that particular period of time. And what we have noticed that endothelial cell loss was maximum at the end of first year, then it is more reaching towards a plateau. And we had secondary donor failure about 6.2% within this period of 5 years. And if you see that only 69 patients at that, this was last year, had completed that 5 years, we have data of 5 years, and at the end of 5 years, the endothelial cell loss was 55%. And this is the curve. You see that in the first year, the endothelial cell loss was maximum, around 37%. Then it is reaching towards, then the endothelial cell loss is not that, it is more of gradual. And these are some of these cases. I have seen some surprise. This is 1 year. With right eye 5 years, left eye you see that it is 3 years. Then this is 5 years, endothelial cell density is 590. This is left eye 7 SM patient. This I had a donor dislocation, and you see that CCT is still higher. These are my initial cases. Then this is 1.2 years. You see the cell density. This was a surprise for me. Then this is 6 years. This is the patient lost to follow up after 6 months. So after 3 months we had a specular, and then again after 6 years, the same patient we had a specular of 1528. The cell, the CCT is also, you see that from here it's reduced. There is another patient, he also lost in follow-up, November 2006, and he is maintaining very good count. So this was my 7th patient, but I went back to my eye-bank specular. It was only 2400. So why I am telling that, there is lot of discrepancy in the IBank specular also. So this data of IBank specular with your clinical specular, even in clinical specular, if you have two different machines, if you are counting over a period of 5-6 years, it is giving you sometimes wrong data. Initially we had HiLab. HiLab used to give lower cell count. Now we have Conan. Conan giving maybe more cell count. Now we are getting 3,000 cell in our IBank. It is more patients are. It is not like that. If we see our clinical scenario, it is around, our average is around 2,500. So these are discrepancy of this study, but the main thing that if you compare this was the study published by Price et al. And this PK series was taken from CDS. And you see that DSEC is going actually good. And if you see this thing, it is also going, that is endothelial cell survival. So these things have to be considered when you go for this kind of data analysis. So if you have one kind of specular microscope and in both the sides, it might be giving good results. So in conclusion, the maximum endothelial cell loss happens during first year post-operatively, then it is gradual over a period of time. And if you see compare with PK, it is always better than DSEC. Thank you very much for your patience.
Thank you, sir. We have the next speaker, Dr. Ashwini. He will be presenting on the topic epithelial accelerated corneal collagen cross-linking, 6 months follow-up.
Good morning, everybody. I will be presenting our outcomes of transepithelial accelerated corneal cross-linking in keratoconus. I do not have any financial disclosures. Conventional cross-linking has always been an epithelium-off procedure with various riboflavin protocols. Till now we were following the conventional cross-linking where it was a 30-minute UVA radiation, and recently various accelerated cross-linking protocols have also been described. However, they all use a similar riboflavin of 0.1% riboflavin with or without dextran, which is isotonic, and it's an epithelium-off procedure. The problem with this is we can perform this procedure only if the corneal thickness is greater than 400 or 420 because of a fear of damage of the endothelium in thinner corneas. With this riboflavin, when we did an in-house study with the anterosegment OCT spectral domain, we noticed that these are the areas where epithelium has been removed, and this is the area where epithelium is present, and we can see that in the areas of epithelium off, there is a greater riboflavin penetration than in areas with epithelium present. In thinner corneas, recently the transepithelial cross-linking has been coming into practice, and one of such formulations which has been introduced by Avedro is used in this study. In this protocol, we are using two different riboflavin drops. The first one is the Paracel drops, and this is a 0.25% transepithelial riboflavin, which is dextran-free and hypoosmolar. It has various preservatives like BAC, HPMC, and EDTA, which is to allow for penetration through the epithelial barrier. The second drop we are using is another riboflavin, which is 0.25% in saline and isotonic. This is the Vibex Extra, which is for rapid action. There are many questions to be answered with the new protocols of cross-linking which have been introduced, which is the ideal UVA intensity, and is faster the better. We also have to answer the questions of efficacy and safety in transepithelial cross-linking. Transepithelial accelerated cross-linking, we just have to take a few moments to understand the Bunsen-Roscoe law of reciprocity, which states that the biological effect is proportional to the total energy delivered, regardless of the applied irradiance and time. That is, it depends only on the total energy. So by increasing the power and decreasing the time, maintaining the total energy, we get the same biological effect. In transepithelial procedure, to maintain this law, a dose of approximately 5.4 millijoules is required at the levels of Bowman's membrane. For this, we give a treatment time of 2 minutes 40 seconds, and the total surface dose in this procedure is 7.2 millijoules, and this is estimated to give a 5.4 millijoules at the levels of the Bowman's membrane. This was a study protocol. Initial 5-minute soak of Paracel drops, which was 0.25% riboflavin with HPMC, BAC, and EDTA, followed by 5-minute soak with Vibex Extra, which was isotonic riboflavin in saline, This was for the rapid penetration of the riboflavin, followed by 40 milliwatt per centimeter square UV light for 2 minutes 40 seconds, giving a total irradiance on the surface of 7.2 millijoules. The corneal thickness in all our patients cutoff was taken around 410 plus or minus 20 microns. We included all patients with documented progression of keratoconus, either on refraction or on topography, and we included the statistical analysis was performed using the PET test. We excluded all normal or atypical patients and any patients with pachymetry less than 375 microns at the thinnest point measured by pentacam. We studied a total of 25 eyes, and the most transepithelial KXL follow-up was at 1 week, 1, 3, and 6 months. This is the spectral domain anterior segment OCT picture taken during the procedure. This is the pre-procedure before the riboflavin soak time. And this is at the end of 5 minutes after paracell soak, where we can see that the riboflavin has diffused just above the Bowman's membrane. And this is at the end of 10 minutes, that is at the end of Vibex extra, where we can see that the riboflavin penetration has gone just beyond the Bowman's membrane. We also studied performed pentacam in all patients at all follow-ups to see the keratometry values, and the Scheimpflug imaging to measure the densitometry. And we performed the Corvus to study the corneal biomechanics, where we measured the deformation amplitude. We also performed specular microscopy to see the endothelial safety of the procedure. These are our results. As we can see, the best corrective visual acuity, the keratometry with both K1, K2 and the mean K had remained stable at 6 months. The deformation amplitude showing the corneal biomechanics has also remained stable at 6 months, and the mean endothelial cell count is also the same. These are the confocal images, where at 3 months post-treatment we can see activated keratocytes, and at 6 months we can see the decreased activity of keratocytes. In our study, we have not noticed any progression in any of the treated patients at 6 months. However, we also did not notice any flattening effect that is usually seen in conventional cross-linking. Also, we did not see any demarcation line which is seen in conventional cross-linking. And we also did not have any change in the deformation amplitude at 6 months. Till now, what we know is conventional cross-linking is proven to be effective and safe for halting progression of keratoconus. What this study adds is the transepithelial KXL may be an effective tool in treating patients with thin corneas where conventional cross-linking is not possible. The take-home message here would be that transepithelial KXL is a safe new procedure for stabilizing progressive keratoconus, but we have to exercise caution before making this a standard of care in all patients, because the changes which we see post-treatment in conventional cross-linking have not been seen in the transepithelial cross-linking. So we can conclude that transepithelial cross-linking can be kept as an alternative procedure in very thin corneas where conventional cross-linking is not possible. Thank you.
Thank you. I think lack of time, we go to the last presentation. I invite Dr. Anthony J. Aldave to present his paper on X-linked megalocornea associated with the novel CHRDL1 gene mutation.
Thank you very much. It's a pleasure to be able to present to you, and I apologize for a genetics talk, but I'll keep it brief, I promise. I have no financial interest in any of the products that I may mention during this talk, but I do have research funding from the National Eye Institute. X-linked megalocornea, you may or may not be familiar with it. It's a rare anterior segment dysgenesis, characterized, as you see on the slide, by enlarged corneal diameter, increased anterior chamber depth, and corneal thinning, although the corneal thinning is typically fairly mild. The gene for this condition was identified 2 years ago by Webb and colleagues. It's a gene called the cordon-like 1 gene. This is X-linked, so this is one of the unusual inherited corneal disorders that is not autosomal dominant. This is X-linked recessive. And we report an additional family with clinical features consistent with X-linked megalocornea in a previously unreported mutation in the CHRDL1 gene. The proband is an 11-year-old boy who presented to me with features of X-linked megalocornea, including enlarged horizontal corneal diameters. You see 15 millimeters in the right eye and 14.5 in the left eye. Of his 3 younger brothers, one was affected with normal, one was unaffected with normal corneal diameters. This is the individual who's in the non-filled symbol here. And then the two other brothers also had enlarged corneal diameters of 14 millimeters each. This is a orb scan from the proband. You see a fairly unremarkable appearing anterior and posterior float. The keratometric map also looks pretty unremarkable. His K value is 44.6 by 43.2. So all these corneas are enlarged, they're not typically steep. What's the most unusual is on the chemistry map, we see central corneal thickness of 458, with the thinnest reading being 446. And we also note that the anterior chamber depth is 6.3 millimeters. So, like the talk we heard about earlier, if you're considering a DSEC for this patient, you wouldn't need a DSEC, but you certainly have a very deep chamber, plenty of room. The results of screening the CHRDL1 gene in this patient demonstrated a novel mutation, as you see as deletion of a nucleotide, which caused a frame shift and then truncation of the encoded protein. The mutation was present in a homozygous state in the proband. Again, remember this is an X-linked disorder, so it only has one copy of this gene, as well as his two affected brothers. It was in the heterozygous state in the proband's mother. The mutation was not detected in the unaffected brother or in 100 control chromosomes. So this will be helpful for you, I think, if you look here. This is the individual 3.2, so this is the unaffected individual. This is the wild type sequence here. This is the nucleotide sequence. You'll notice there's two C nucleotides. However, in the three affected individuals, you see one of the C's is deleted. So the sequence looks normal, but if you compare it to the wild type, you see there's a nucleotide missing. And then in the mother, as you see depicted here, she is heterozygous. So here's the wild type, one strand has this nucleotide, other strand does not. So this looks like a frame shift here on the mother's sequence. And so we describe a novel deletion in the CHRDL1 gene predicted to cause a truncated protein product. This identified deletion segregates with the affected phenotype in the family in which it was identified. This is the first confirmation that CHRDL1 mutations are associated with X-linked megalocornea. And the identification by Webb and colleagues of a different mutation in each family, and the fact that the mutation that we described here is previously unreported, indicates that if you have a patient with X-linked megalocornea whom you suspect of having this condition, it's not enough to just look for the previously reported mutations, because every family to date has a novel mutation. So the family that you have will probably have a novel mutation as well, which means that screening of the entire coding region will need to be performed in order to confirm the diagnosis. If you're interested in learning more about this family, this report just appeared in Ophthalmic Genetics about 2 months ago describing this family, and I thank you very much for your attention.
Thank you very much, Tony. You take some time in evaluating the results, so try to be patient. Thank you. Waiting for the results. It is really an excellent session with lovely papers, a lot of statistics and new techniques and technology. But we thought one particular paper really stood out, and it was by Dr. Samar Prasad, periodical endothelial cell loss in DSEC, consecutive 550 cases over 5 years. I would like to congratulate Dr. Prasad. He's here. Thank you, everybody. For the diocese, a big support and a help will be valuable. Thank you. Thank you.
Good morning. We all know that limbal stem cells have a great role in maintaining the ocular surface, and any damage to it can lead to limbal stem cell deficiency. treatment of which would be stem cell transplant. The technique described was CLAU, where 6 clock hours of healthy limbal tissue is taken from the healthy eye. Good results have been reported, but then there are chances of LSCD in the other eye. To overcome this came cultivated limbal epithelial cell transplantation, which showed very good results. But the thing here is you need a state-of-art stem cell lab. So can you have a CLET-like result in LSCD patients without need of stem cell lab? The answer is maybe yes. Sangwan et al. Published this article in BJO where they described a technique called simple limbal epithelial cell transplant. They described 5 cases with 9-month follow-up and had a good results. With this background of mind, we conducted a retrospective study at our center, which was prospectively collective data of unilateral LSCD patients that underwent SLET over a period of 5 years. Previously described clinical definition of LSCD was used. This study was approved by LVPA Institutional Review Board and written consent was taken. Let's have a look at the video how the surgery was done. First, limbal biopsy was taken from the healthy eye. 2 to 3 clock hours, 2 clock hours of limbal tissue was procured. Once I reached the limbus, blunt end of the 50 number blade was used. The pigmentation in the limbal area that was used as a guide. This was the strip which we were interested in, and this was the conjunctiva which was not used. And this particular strip was dissected. It was very important while dissecting to go slightly in the clear cornea also, so that you can have all the tissues intact. It is important not to use any crushing forces to secure these. This strip was secured and the other eye was draped, which was the diseased eye. 360-degree peritomy was done, and then all the pannus was removed. If you have done an initial AMG, the things becomes easy and you can actually do the nice dissection. Once the full dissection was done, it was covered with amniotic membrane, wet amniotic membrane with stromal side down. This was for nicely whatever size was needed, that was cut. Extra side was stuck below the conjunctiva. It was secured with the help of fibrin glue. Here Baxter was used. So once the amniotic membrane was nicely placed, then it was again over the amniotic membrane. There's a drop of fibrin glue that was instilled, and then lenticules were cut from the limbal healthy tissue, the strip that was taken. As you can see, this is the first lenticule. This is spread all over the cornea. It is not necessary to place only on the limbus. You can spread all over. Then multiple 8 to 10 pieces were cut and placed, secured with fibrin glue. It was covered with BCL. Let's have a look at the results. Pre-op data, the patients had either thermal or chemical injuries, and they had gone multiple surgeries at the time of acute phase. As a representative, this was a case who was 4 years old male child. After acute phase, this was what it was left with, total limbal stem cell deficiency, underwent SLET. This is 18th post-operative day. This is 3 months. The epithelium that is coming, that seems to be of corneal phenotype, and this is 2.5 years. I thought that the patient was 636 and amblyopia therapy in the form of patching other eye was continued. There was slight recurrence, as you can see here in the same child. This was managed by top-up SLET, where there was this procedure was repeated along with conjunctival autograft. As you can see, these are the lenticules over the amniotic membrane, and the epithelium is coming from the lenticules. Slowly it is increasing and ultimately epithelialized completely. So over a period of 45 months, child maintained a good ocular surface. Another patient who had a firecracker injury, 360-degree limbal ischemia. These are the set of surgeries that were done in the acute phase, and this was what was left with total limbal stem cell deficiency. Underwent SLET. This is the intraoperative pictures, and the ocular surface was quite stable within 3 weeks, and he maintained good ocular surface over 7 months of follow-up, and is awaiting penetrating keratoplasty. Post-operative data, as you can see, we had a follow-up of average follow-up of 22 months, which is much higher than the previously reported article. We had partial recurrence in 2 cases, which was managed by top-up SLET and CHE. These 3 cases had, out of 6, these 3 cases had comparatively milder form of LSCD, and these 3 cases had a very severe form of LSCD. But this technique can be really revolutionary because you don't need a stem cell lab. and then it's a single stage procedure, and then the results seems to be comparable to the cleft. In conclusion, it's a simple technique, and it seems to be quite promising, and it can be done even by a general ophthalmologist. Long-term results with large studies from multiple institutions are awaited. Thank you very much.
Thank you, Dr. Nikhil. I would like to ask a question. How did you manage to cut that tissue into 6 small bits? What instruments you used without crushing and everything?
Okay, so what I did was, it was stored in BSS, and when I was planning to place it, I used a 15 number blade and on a Teflon block and chopped it. It was while chopping it, it was taken care that there is no crushing force. One single good confident force is used to chop it into multiple pieces. 8 to 10 such pieces were made. You can also do it on the surface while using Vana scissor. Again, here also you have to have one single cut and no crushing force.
Thank you.
Thank you very much.
Is this with any financial disclosures like?
That was the first disclosure. There was the first slide. I didn't have any financial disclosure. That was the first slide. This was the first slide.
Okay, thank you.
Thank you very much.
Now we invite our next presenter, Dr. Abhishek Dave. He will be presenting his paper on outcomes of CXL in pediatric patients and its comparative evaluation with adult CXL.
Good morning, everyone. I'll be presenting our outcomes of CXL in pediatric patients and its comparative evaluation with adult CXL. No financial disclosures. So amongst the known modalities of treatment for keratoconus, collagen cross-linking is one entity which has the potential to halt the disease progression and probably to reverse it to some extent as well. Its efficacy and safety in adult CXL is well known. So our aim was to evaluate the outcomes of collagen cross-linking for progressive keratoconus in patients less than 18 years of age and to compare its efficacy with that of adult CXL. Carried out at the cornea services of Shankar Nethralaya, Chennai, it was a retrospective interventional study. Patients were divided into 2 groups of pediatric and adult, consisting of 176 eyes of 135 patients, and the adult group consisting of 150 eyes of 118 patients. Isotonic CXL was performed in all the eyes according to the Dresden protocol. Inclusion criteria was age less than 18 years, documented keratoconus progression, and thinnest ultrasonic pachymetry more than 400 micron. Patients with thinnest ultrasonic pachymetry less than 400, patients undergoing hypertonic CXL, and patients with other contraindications of CXL were excluded. The parameters evaluated were the best spectacle corrected visual acuity, the best contact lens corrected visual acuity, the spherical equivalent refraction, the objective and the topographic cylinder, the thinnest pentacam pachymetry, the pentacam Kmax, and the specular count. So the mean age of patients in the pediatric group was 14.3 years, and that in the adult group was around 26 years. Around 70% of the patients in pediatric group were males, and 64% in the adult group were males. Of the 135 pediatric patients treated, 41 were treated bilaterally, and of the 118 adult patients treated, 32 were treated bilaterally. Around 5% of patients in both the groups had a family history of keratoconus. Around 20% of patients in the pediatric group had a history of VKC, while around 12.7% patients in the adult group had a history of VKC or allergic conjunctivitis. Coming to the results, there was no significant improvement in the best corrected visual acuity or the best contact lens corrected visual acuity over a period of 1 year, though the vision was stable over this period. There was no difference in the visual acuity between the groups as well. The spherical equivalent refraction decreased significantly in both the groups. However, there was no significant difference between the two groups. Both the objective cylinder and the topographic cylinder decreased significantly in both the groups. However, again, there was no significant difference in between the groups. The mean pentacam Kmax decreased by around 0.93 diopters in the pediatric group and around 1.06 diopters in the adult group. There was a significant flattening seen in both the groups. However, there was no significant difference between the groups again. The thinnest pentacam pachymetry decreased significantly in both the groups. We further subdivided the groups into mild, moderate and severe keratoconus based on the Amsler-Greenwich classification. Also into thin and thick preoperative corneas based on the preoperative pachymetry, whether it was less than 450 or more than 450 microns. We compared the effect of preoperative Kmax on the flattening scene, and we saw that there was no difference in the flattening in the pediatric group between the mild, moderate and severe keratoconus. However, in the adult group, there was a significant more flattening seen in the severe keratoconus group. There was no significant difference in the flattening produced based on the preoperative pachymetry in either of the groups. There was a significant decrease in the specular count noted in the pediatric group. We didn't have the data for the adult group, which was significant, but clinically there was no evidence of any decompensation noted in any of the corneas. So to conclude, CXL in children results in stabilization of the visual outcome. It leads to improvement in the refractive and keratometric outcomes. It can cause an early arrest of disease progression. Results are comparable to CXL in adults, and the decrease in endothelial cell count noted in our study, however, is a cause of concern. Keratoconus progression in children is much frequent and faster than in adults, around 88%. The visual impairment affects the social and the educational development of the child. Corneal transplant in this age group has a poorer prognosis. So CXL comes in because it can avoid a keratoplasty. However, its efficacy in children is a concern because of the higher viscosity and the lower resistance of younger corneas. And also there is a need for standardizing the treatment protocol for pediatric patients. If you compare our study with the previously published studies, we see that our study has a much higher number of patients. It has the advantage of it being a comparative study with adult patients as well. However, the disadvantage is that it's a retrospective study and the follow-up is only 1 year. All studies show a significant improvement in the corrected visual acuity at 1 year, but our study showed a stabilization of the vision. Like all studies, our study also showed a significantly reduced spherical equivalent refraction and Kmax. The pachymetry was stable in the other studies, except for one of the studies by Dr. Ritu Arora et al. But our study also showed a significant reduction in pachymetry in 1 year. So we recommend a close follow-up of children with keratoconus and prompt CXL on the earliest signs of disease progression. Thank you.
Thank you, doctor. But considering the endothelial cell count damage, the children need close follow for a longer period to say that this is safe in children.
Definitely, ma'am. It needs a regular follow-up. This was one disadvantage that it was 1 year follow-up only. And secondly, there are some of reports of regression also noted in pediatric patients.
So how did you decide about progression in children, and how long did you wait for progression to see whether you go for CXL or not?
We define progression as greater than 1 diopter increase in the CK over a period of 6 months. We followed this for both pediatric and adult.
So you saw for 6 months, and then if it was progressing, you went for that?
Yes.
Thank you.
यही से मार दिया हो रहा है, वहाँ से दिक्कत आती है.
We call upon the next speaker.
चेयर चेंज करा दो, मैंने कही थी यार.
Dr. Gurdev Singh.
The study was conducted in Cornea Department of Nagar Nethralaya, Bangalore. Patient gave written consent for the study, which was approved by the ethical committee. These were the inclusion criteria of the study, which included a diagnosed case of total limbus sensor deficiency on slit lamp examination, which included a complete disappearance of the palisades of Vogt in the limbal area, those with a persistent epithelial defect or recurrent ulceration, neovascularization and conjunctivalization, and these were the exclusion criteria, excluding infectious eye disease, history of acute phase of ocular inflammation, history of neoplastic disease, those with the glaucoma and total similar frown. Efficacy of the procedure was judged in the form of primary outcome and secondary outcome, primary outcome being a total healed epithelial defect, absence of conjunctivalization and decrease in the corneal vascularization in the follow-up period, secondary outcome as improvement in the presenting symptoms like photophobia and watering, central corneal clearing and improvement of visual acuity. Success of the procedure was regarded when all the 3 criteria either improved or they remained stable at the mean follow-up period. Failure if at least one criteria worsened or if one criteria that was subnormal at the inclusion period remained stable at the follow-up period. Now, this is how we went across the period with the procedure. First, the preparation of the case is done by taking care towards the oral hygiene in the form of taking care toward tooth decay treatment, total complete abstinence from alcohol or tobacco, regular toothbrushing, and iodine gargles. Once the oral hygiene improves, then we take oral biopsy, which is taken as 3 by 3 millimeter of oral biopsy. Then it is implanted on the amniotic membrane, cultured on human corneal epithelial media at 37 degrees centigrade for 2 weeks. Once the monolayer develops, then the graft is ready for culture. This is how it is showing how the culture is happening on 1 day. Then the formation of semi-confluent layer, which is usually seen at 1 week period, and once the confluent monolayer develops, which we will be seeing by daily observation on an inverted phase contrast microscope. Once the monolayer is ready, then the graft is ready for implantation. These were our results. 7 eyes of 4 patients, all males with median age group of 25, with mean follow-up period of 12 months, with the longest follow-up period of 24 months were included in the study. Etiology mainly consists of 86% of cases of chemical injury and 1 case of Stevens-Johnson syndrome. Now, this is a case sheet where you can see that in all of the cases where the initial presentation was with ulcer, at 1 year follow-up, no ulcer was seen except in the 6th number case, where at the end of the 1 year follow-up period, we noticed a moderate epithelial defect, whereas in the initial present there was no ulcer. An increase in the conjunctive vascularization was seen at one of follow-up period. So this was regarded as one of the failure cases among those 7 eyes. So epithelial defect improved in all 6 out of the 7 cases, 86% of the eye. Conjunctivalization was seen in 1 out of the 7 eyes. In all the cases, peripheral neovascularization to moderate degree manifested without markedly affecting the visual function. Primary success outcome of the procedure was 86%. Visual acuity improved from average pre-op period to post-op period of 20 by 300 with 1 eye to 20 by 25, for which PKP was done at the later stage. All patients had improvement in their subjective symptoms like photophobia and watering. None of the eyes developed any serious ocular adverse effect like corneal perforation. This was one of the cases presenting with a bilateral limbus sensor deficiency following a chemical injury with tuna. And you can see how promising the result of Comet can prove. These are the 1 month, 3 month, and 6 month post-op period. And you can see in the left eye where the PKB was done, the results can be very much promising. So reconstruction with autologous Comet offers substantial clinical advantage over allogenic transplantation for treating severe and bilateral diseases like Stevens-Johnson syndrome. It averts the risk of allogenic immune rejection and immune suppression associated with allografts. In our study, modest peripheral corneal neovascularization was observed within a few months after transplantation of cell sheet, which was also reported in various other studies. Transplanted buccal mucosa cells survive by means of vessel canalization. High success rate attained in our study can be related to 86% cases of chemical injury cases which were included in our study. So at the end, we concluded that the cultivated autologous oral mucosal stem cell transplantation constitutes a promising treatment in patients with severe and bilateral ocular surface disorder. Thank you.
How long were these patients followed up?
Ma'am, average follow-up was 1 year and the longest follow-up was 2 years.
And this remained transparent? This became
The thing is, in other studies, it has been shown, even if it goes for, even the limbus sensor deficiency again happens, you can repeat the procedure. It is quite a repeatable procedure because it is from the oral mucosa we are recurring.
In which medium is it grown?
Ma'am, human corneal epithelial medium.
How is it prepared? Any idea?
Ma'am, it's readily available. This thing, it has buffered. So many constituents are there,
it is a routinely used medium by the pathologist?
No, ma'am, it's not. It's especially for the stem cell laboratory.
Oh.
It contains various factors like arginine, so many amino acids and for the growth.
Okay, thank you.
Stevens-Johnson also involves the oral mucous membrane. So,
yeah,
the patient who...
This was the case where the involvement was not that much, so we could procure the oral mucosa there. Thank you.
There is slight change in presentation. I invite Dr. Vipul Bhandari for his paper on visual and clinical outcome of cases undergoing Descemet's membrane endothelial keratoplasty. He has to do a presentation in another hall. That's why this change in presentation is there.
I have no financial disclosures to make. So coming on to the topic, corneal endothelial dysfunction is a major cause and indication for corneal transplantation. Until 1998, penetrating keratoplasty was the only option for us, and as all of us know, there are limitations of PKP, suture removal, early rejection, graft edema, and etc. So Dr. Mellies introduced the posterior lamellar keratoplasty at advantages over the classical penetrating keratoplasty, a rapid improvement in visual function, lower incidence of serious complication, and higher comfort for the patient with related to sutures. And the basic thing is, when the endothelium is primarily diseased, why not replace only the endothelium? So this is the option we have got, descent membrane endothelial keratoplasty. The main aim of the study was to evaluate the visual outcome, endothelial cell density, and complications of DMEC. Study sample, initially when we submitted the abstract, we had done only 6 cases. So 6 size of 6 patients undergoing DMEC for various endothelial pathologies at Shankar Eye Hospital, Coimbatore, and the study duration was 8 months, that is the follow-up, and informed consent had been taken from the patients. Main outcome measures were the postoperative best corrected visual acuity, endothelial cell density, and the complications. This is the video. From the donor, and it is trypan blue stain, and you can see a Sinski hook is used to score the DM. Actually, process called despitoresis. Now we're scoring the DM. We lift one edge of the DM slowly and use a forceps. And as we perform a capsulorhexis, we perform a despitoresis. Note that we have to hold the edges of the DM, and this is stored in the PSS. So now we made a customized cartridge for injection of the DM tissue, consisting of a 1 ml syringe and a holder for placing the PSS, and a silicone tube, and a front part of the Technis 1 iron cartridge. This is the way to assemble the unit. And this is the whole unit. I'll just show the whole process of DMEC.
Video content in your folder.
So, donor endothelial cell density was analyzed by the Conan keratoanalyzer, and in patients, a top-con specular microscope was used. These are our results of 6 patients. In the first patient, the procedure had failed, and we had to convert into PK. And all the rest other patients have a postoperative visual acuity ranging from 618 to 66. The age of the patients were ranging from 20 to 65 with a mean age of 47, and the mean endothelial cell density of the donor tissue was 2,479, and at 6 months it was 2,144. The mean reduction was around 13.51%. So the overall visual recovery in DMEC compares favorably to PK and earlier endothelial keratoplastic like DSEC and DSEC. Main indications for DMEC in our study was failed PKP and PBK. So our study shows results similar to Mellies and Guerrera et al. But the main thing in our study, the endothelial cell count was only about 13%, while the Price et al. And Mellies have shown endothelial cell loss of around 30 to 43%. So our study shows that DMEC is a favorable procedure compared to other keratoplasty, but a relatively steep learning curve and may require specific training in surgical handling and tissue handling. These are my references. Thank you.
So how do you make sure that the endothelial side is down and the other side is up?
Because when we inject it into the anterior chamber, we have to make sure that the DM unfolds with the endothelium down. That is, we get it with experience.
How do you make sure that?
We get it with experience. We cannot make out. Most of the people have asked me similar questions. We cannot make out 100% perfectly whether it is. It unrolls that way.
So once you have kept your desmoids and saline, you
Yeah.
don't know which side is endothelium and which side is not. So how
It will never unfold in the other.
It never unfolds the other. It unfolds with the endothelium side facing back.
Thank you, doctor. Now we will call upon the next speaker.